Hello, I just wanted to first thank Margie and Ann for inviting me to do this video. I am actually in the middle of the Mission District in San Francisco, working as a visiting scholar on community engaged research at the moment. And so I think it's quite timely to really talk about structural determinants of health and how these structures and institutions in the community really can affect the way in which our patients receive care. So my name is Ayana Jordan. I am an addictionist. I specialize in people with all types of addiction, and my specialty really is focusing on those with substance use disorders. And so the case that I want to discuss is really, I think, exemplifies ways in which structural determinants of health can really affect the way in which our patients receive care, but also the way in which we talk about care in general. Let me be specific in what I mean. Firstly, I wanted to talk about a young woman. She was Black in recovery for a cocaine use disorder and had been doing really well initially in treatment, but then after probably about 30 days, about a month, or maybe 5 or 6 weeks of care, we stopped seeing her altogether. And within her chart, over and over again, would be treatment non-adherence, medication non-adherence, and there was discussion about kicking her out of the clinic because she had no-showed for so many reasons. And so everyone kind of agreed in rounds that she was no longer engaged in care, that she most likely had lapsed and had started using again. But one of the things I really challenged within that example is trying to understand if anyone had actually connected with the patient to figure out why, after doing so well for about 6 weeks, why she had stopped coming. And so what's really nice about this example is it highlighted that this particular patient actually was still very much interested in care. I actually reached out to her to kind of call and see what was going on. And the issue was not that she had lapsed at all, but that she actually was trying to protect her recovery by avoiding the area where she knew a former drug dealer, or the person was still a drug dealer, but where she used to get drugs from, had changed their particular selling spot. And so the selling spot of where that person sold drugs is very close to the bus stop where the patient has to go in order to come to the clinic and get care. And so she just did not want to be tempted, and it was too much of a risk for her to now go to that bus stop and receive care, because she knew that she would come into close interaction with the drug dealer, and that would be too much of a trigger for her. So instead of doing that, she just decided, I'll have to lay low for a bit, and then when I figure out a way to get into clinic, I can go back. So again, treatment providers were saying, oh, she is, not interested in care. She probably lapsed. But this is a very nice example of really trying to understand the structures in her environment that really led to her not being able to get care anymore. And in this particular case, it was that the place in which she had to catch the bus had now been taken over by a drug dealer, and she did not want to risk her recovery by going to the bus stop in order to get to the clinic. And so that was just a simple fix. What we were able to do is work with Medicaid to get work with an institution called Logisticare, and get her passes, basically so she could use a taxi to come to the clinic, as opposed to having to catch the bus. So anytime that she would have to have appointments, we just needed to send to Logisticare. They would send a taxi, the patient was able to come in, get treatment, and then go home. And for a matter of time, that worked really, really well. So again, I think that is a nice example of how, before we automatically blame the patient and say that this person is not interested in care, we really have to understand the structures or the institutions, and here it was the patient's environment, that really can affect how someone interacts with care. Thank you.